Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Today, we're diving deep into one of the most transformative advances in oncology, autologous CAR T-cell therapy. This is for all the healthcare professionals out there. We're going to break down the entire incredibly complex clinical process from start to finish, what we call the vein-to-vein journey.
So, here's our game plan. We'll start by wrapping our heads around this idea of a living drug. Then, we'll cover how patients are selected and their cells are collected. After that, we dive into the amazing science of engineering the therapy itself. We'll then walk through preparing the patient and the infusion. And finally, we'll tackle how to manage the acute toxicities that can come with it.
All right, let's kick things off with Section 1. Before we get into the nitty-gritty, we really have to understand what makes CAR T-cell therapy such a paradigm shift and get a feel for the timeline that dictates everything.
At the heart of it all is the CAR, the chimeric antigen receptor. Think of it like this. We're giving a patient's own T-cells a new set of eyes and a GPS. This synthetic receptor lets the T-cell lock onto a specific target on a cancer cell, like CD19. But here's the truly revolutionary part. It's MHC independent. This is a total game changer, because it means our engineered T-cells can hunt down and destroy cancer cells, even when those cancer cells try to pull off their favorite magic trick, hiding from the immune system by getting rid of their MHC proteins.
And this visual right here, it perfectly captures the entire journey, which we call vein-to-vein, or V2V. It literally starts with a needle in the patient's vein to collect their cells, and it ends with a needle in their vein to infuse the final product. And as you can see, this is a marathon, not a sprint. The whole thing, from the initial evaluation all the way to the end of acute monitoring, can easily take 3 months. And that big chunk in the middle, manufacturing, that's the single biggest delay.
Now, this number, 40 days, is absolutely critical. You have to understand that the vein-to-vein time isn't just a number on a chart. It's a powerful clinical variable. For patients with aggressive cancers like large B-cell lymphoma, the clock is always ticking. And we have real-world data showing that if this process drags on for more than 40 days, the patient's outcome, including their overall survival, gets significantly worse. It is a literal race against the disease.
And you know, not all CAR T products are created equal when it comes to speed. Just look at this chart comparing the typical vein-to-vein times for the main players in large B-cell lymphoma. You can see axi-cell is consistently the fastest, while T-cell takes the longest. And these differences aren't just academic. They can absolutely influence which product you might choose for a patient whose disease is really moving fast.
Okay, that brings us to our second section. Before we can even think about manufacturing, we have to secure the two most important ingredients, the right patient and the highest quality starting material, their own T-cells.
The selection process is and has to be incredibly strict. Of course, the patient needs to have the right type of cancer, but they also have to be physically fit enough for the journey. That means an ECOG score of 0 or 1, so they're mostly up and about. Their heart, lungs, kidneys, and liver all have to be in good shape. And the logistical demands are just as tough. Having a dedicated caregiver 24/7 and being able to live near the hospital for a month after infusion, these are absolute non-negotiables for patient safety.
I love this quote. It's such a powerful way to think about it. The bag of T-cells you collect from the patient? That's a direct snapshot of their immune system's health. And the reality is, patients who've been through round after round of chemo often have T-cells that are tired, worn out, and just exhausted. This poor quality starting material not only raises the risk that the manufacturing will fail, but it's also linked to worse outcomes. It's a huge reason why the conversation is shifting toward referring patients for CAR T earlier.
Now, to get the best possible T-cells, patients have to stop certain drugs for a while before collection. We call this a washout. For something like steroids, it might be just a few days. But for really potent drugs like bendamustine, it can be weeks, even months. And this creates a huge clinical catch-22. How do you keep an aggressive cancer in check while you're holding back the very therapies you need to in order to collect the cells you'll use to treat it? It's a real balancing act.
All right, now we're moving from the bedside to the lab. This is where the magic happens. It's where a patient's ordinary T cells are transformed into a precision-guided, cancer-hunting living drug. The whole thing is a highly sophisticated four-step dance done under the strictest clean room conditions. First, the T cells are pulled out and purified from the rest of the blood product. Second, they're activated, basically woken up and told to get ready for a change. Third, they go through transduction, where a harmless virus acts like a delivery truck to insert the CAR gene into their DNA. And finally, that small batch of newly minted CAR T cells is grown in a bioreactor until it becomes an army of billions.
So how do we get that new gene in there? Well, we use a viral vector, and there are two main flavors. You've got gamma retroviral vectors, which are used for products like Yescarta. They can only modify cells that are actively dividing. Then you have lentiviral vectors, used for Kymria and others. They have a neat advantage. They can get into both dividing and non-dividing or resting cells, and this might let them engineer more of those long-lasting memory T cells, which could lead to more durable responses for the patient.
Before a single one of those cells gets shipped back, the final product has to pass an incredibly tough battery of quality control tests. Think of it as the final exam, and it has to get a perfect score. They test for sterility to make sure there's no contamination. They check purity to see what percentage of cells actually have the CAR. Viability to make sure the cells are alive and kicking. And potency to prove they can actually kill tumor cells in a petri dish. Only when it passes every single test is that product released. Okay, the cells are engineered. They've passed their tests, and they're on their way back to the hospital. The focus now snaps right back to the patient. It's time for the final prep work before they receive their personalized medicine.
Now, this is one of the most important concepts to get right. In the few days before the CAR T infusion, the patient gets what's called lymphodepleting chemotherapy, or LDC. But, and this is key, its purpose is not to kill more cancer cells. Its job is to prepare the patient's body for the incoming T cell army. It's like tilling the soil before planting seeds. It clears out the patient's existing immune cells to make space and gets rid of competitors that would otherwise soak up all the growth factors the new CAR T cells need to thrive.
The gold standard for this is a 1-2 punch of fludarabine and cyclophosphamide, or Flu-C. Adding fludarabine was a pivotal moment in the history of this therapy. It dramatically improved how well the CAR T cells expanded and, in turn, how well patients did. While Flu-C is the standard, the exact dosing and timing depends on the specific product. For Yescarta, for instance, it's 3 straight days of both drugs starting 5 days before infusion.
Then comes infusion day, the moment this entire journey has been leading to. Safety here is everything. There's a painstaking chain of identity check to make 100% sure the right cells are going to the right patient. They get standard pre-meds, but critically no prophylactic steroids, which can harm the CAR T cells. The frozen product is thawed right there at the bedside and has to be infused within 30 minutes. And here's a huge red flag warning for the clinical team. Never, ever use a leukocyte-depleting filter. You would literally be filtering out the entire dose of the medicine.
The cells are in. The living drug is at work. And now the most intense part of the clinical management begins, round-the-clock monitoring for the 2 unique and potentially severe toxicities that define this therapy.
First up is the most common toxicity, cytokine release syndrome, or CRS. Really, it's a sign that the therapy is working, maybe a little too well. It's the clinical fallout from the CAR T cells finding their targets and unleashing a massive storm of inflammatory signals. We grade its severity based on 3 very simple clinical signs: how high the fever is, how low the blood pressure goes, and whether the patient needs oxygen.
So, how do we manage it? It's all grade dependent. For a mild grade 1, it's just supportive care, Tylenol and fluids. But grade 2 is that critical line in the sand. That's when you pull the trigger on tocilizumab, an antibody that blocks the IL-6 receptor, a key driver of the inflammation. For severe life-threatening grade 3 or 4 CRS, the patient needs to be in the ICU, getting more tocilizumab, and adding corticosteroids to broadly quiet down the immune system.
Then we have the second major toxicity, which we call ICANS, Immune Effector Cell-Associated Neurotoxicity Syndrome. This is a complex and sometimes scary neurologic syndrome. To track it, we use a simple 10-point bedside cognitive test called the ICE score. And as you can see from the table, the grade is a combination of that score and other neurologic signs. A grade 2, for example, is when their ICE score drops and they're only waking up to your voice. Any seizure automatically bumps it to a grade 3.
Now, here is the most crucial difference in how we treat ICANS. The go-to weapon is corticosteroids. Unlike with CRS, tocilizumab doesn't really work here. It doesn't cross the blood-brain barrier very well and just doesn't hit the right targets for neurotoxicity. So for any ICANS that's grade 2 or higher, the standard of care is to start steroids and start them quickly.
So when you step back and look at this whole vein-to-vein process, it is an absolute marvel of science and logistics. But it's also incredibly complex, expensive, and time-consuming. And that leads to this final, huge forward-looking question. What if we could just skip that whole external manufacturing process? New technologies are being developed right now to try and modify T cells directly inside the patient's body. If they succeed, that kind of revolution could make the entire vein-to-vein journey we've just walked through a thing of the past.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.